Hello, welcome to this webinar on the challenge of diagnosing cow's milk allergy. I'm Dr. Yvan Vandenplas, based in Brussels, but this webinar is also presented to you on behalf of the whole expert group on CoMiSS, the cow's milk symptom score. And this is a photo of our group of international key opinion leaders on this topic. Why is the diagnosis of cow's milk allergy so challenging? Well, there is IgE-mediated allergy, where we have reliable diagnostic tests, IgE and specific rust, and there is a clear relation between ingestion and appearance of symptoms. But some children do also have non-IgE mediated allergy, and that's a real challenge because symptoms are aspecific and there is not a clear, reliable diagnostic test. And according to available data, up to about 1 child in 4 has no cow's milk specific IgE in the serum, although they are allergic. So there is no laboratory test that helps us to diagnose non-IgE mediated cow's milk allergy. That's why with this group of experts, we developed the CoMiSS, the cow's milk related symptom score, as a helpful tool which may make the healthcare professional aware of the possibility that that child may present cow's milk allergy. And with the ESPGHAN group, the European Society of Paediatric Gastroenterology, Hepatology and Nutrition, we just published a paper saying that to diagnose cow's milk allergy, you need a positive oral food challenge test, which means you need an elimination diet and then reintroduce the cow's milk to make symptoms relapse. However, many parents do refuse this challenge test. So that's why the diagnosis of non-IgE mediated allergy remains a challenge. And Dr. Rosan Meyer will now present us more about this procedure on how to manage the diagnosis of cow's milk allergy better in those children who present with non-IgE mediated cow's milk allergy. And Dr. Meyer is a pediatric dietitian and honorary senior lecturer at the Imperial College in London and a visiting professor of the KUL Leuven in Belgium and University of Winchester in the United Kingdom. Dr. Meyer, you have the word now.
Yvan, thank you very much for that kind introduction. And yes, I'm going to take you further on this journey on why it's so challenging to diagnose cow's milk allergy. I want to start off with my conflict of interest and want to declare up front that I'm also part of the CoMiSS expert panel and have been contributing to many of the CoMiSS publications. I think a good starting point is to look at the prevalence of cow's milk allergy. And I think the Europreval study, which to date is the largest prevalence study looking at cow's milk allergy, immediately highlights the problem that we see with the diagnosis of cow's milk allergy. So whilst your overall prevalence was 0.59%, looking at the graph in front of you, you will see the total cow's milk allergy per country in blue, and then in gray, the percentage of IgE, which means the rest of it is non-IgE mediated allergy. If you look at United Kingdom, one of the highest countries in terms of prevalence, you'll see a little bit more than half of the patients have got a non-IgE mediated cow's milk allergy. But if I now focus you to Lithuania and Spain, you immediately will see that apparently Lithuania and Spain have no non-IgE mediated allergy. We have already seen a difference also in the prevalences that are published from previous challenge-proven cow's milk allergic prevalence studies, where you'll see that it ranged between 1.8 to 7.5%. So there is a problem. There is something that makes this an extremely challenging diagnosis. So let's think about the classification. Many of you will know that DRACMA has recently published part of their series, and this part is on the classifications going through IgE, non-IgE, and that tricky category of mixed IgE and non-IgE mediated allergies. You will also know that these different types of allergies cover different systems: the skin, the respiratory tract, gastrointestinal tract, cardiovascular system, and then there are some miscellaneous symptoms as well. When we're thinking about the classification, we need to somehow translate this into symptoms. So what I've done is I've taken each one of the systems and given you the symptoms that are listed by the most common guidelines. This includes, for example, in the digestive system, infrequent regurgitation, colic, abdominal pain, vomiting, diarrhea, for example. For respiratory symptoms, you get listed under cow's milk allergy, wheezing, runny nose, chronic cough. In skin, you get urticaria and atopic eczema. But the problem here is that under each one of these systems and symptoms, you will find that the symptoms are also commonly reported under other diagnoses. So, for example, diarrhea can be a viral or bacterial diarrheal episode, or in some children, secondary lactose intolerance. Constipation has a variety of different origins. It's not necessarily related to a cow's milk allergy. Bloody stools also, up to 20% of infants have hematochezia, and this spontaneously resolves. Even failure to thrive is a symptom that we see for many diagnoses. And you can say exactly the same for respiratory symptoms. A runny nose, cough, wheezing can be seen with upper respiratory tract infections. And as Yvan had already highlighted, many children have got eczema without, in fact, having that being linked to a cow's milk allergy. So this is part of the challenge of the diagnosis. Now, we are aware of this overlap in symptoms. And recently, the EAT study, that's a study on early acquisition of tolerance, where they looked at children that were breastfed with early introduction of allergens versus standard introduction. They looked at the symptoms. And in the graph in front of you, you will see the big circles represent the symptoms that are commonly reported by the parents, which includes vomiting, includes colic, it includes eczema, and then the association that the carers see with it being associated with milk. And then the small circle are only those that were challenge proven positive. This overlap in symptoms is not abnormal in terms of the general population. And our chair, Professor Vandenplas, has shown that in many of the children in global figures, you'll see colic, regurgitation, constipation, or diarrhea. So these are common symptoms. So it does not also come as a surprise that if you were to use a commonly used guideline, and in this case, the same authors of the previous study have used the IMAP guidelines, which is the International Milk Allergy guidelines, based in particular on non-IgE mediated allergies. So if you were to use those guidelines and use the symptoms that they list, for example, the colicky or persistent irritability, vomiting or reflux, food refusal, diarrhea-like stools, constipation, abdominal discomfort, blood and or mucus in the stools, that if you were looking at the severity, 1 in 11 children would have 2 or more of the severe IMAP symptoms, and 3 out of 4 with 2 or more of the mild to moderate IMAP symptoms. Now, I'm sure most of you think this is not surprising, because a guideline was never used to just be used for ticking off symptoms. And no diagnosis should you only be thinking about ticking off symptoms. It's also thinking about the clinical presentation and, like a puzzle, putting it all together. But clearly, all of this has got consequences. And the consequence really is that we have a diagnosis with overlap of symptoms, in particular around non-IgE mediated allergy. And part of the challenge is not only the overlapping of symptoms, but it also may take days for symptoms to appear. Typically, a delayed reaction can take 24 hours, 48 hours. This can be extremely complicated, in particular in the time when complementary foods are introduced. So it might be that within 2 or 3 days, families have introduced egg and wheat, in addition to yogurts and cheeses. So finding cause and effect. And of course, you can understand that the symptoms are often ambiguous. What is the cause? What is the effect? Especially if these symptoms like colic or constipation or diarrhea are so commonly seen in general pediatrics outside of cow's milk allergy. As Yvan had already mentioned, outside of EOE, which has a very clear diagnostic criteria using endoscopy, there's no reliable tool for the diagnosis of non-IgE-mediated allergy. So the diagnosis occurs through elimination and reintroduction. And as we already heard, often this does not occur because parents are refusing, but it also lies with our healthcare professionals that children are lost for follow-up, that as our guidelines say, they should be having a reintroduction between 2 or 4 weeks, depending on the guideline you read for a challenge. It might be that that doesn't occur for months. And I think this is where the problem lies, because we do see the problem with overdiagnosis. And I thought it's quite nice going through an example. This is a very personal example of a patient that I've seen, and I hope you can identify with that. So this is a child that presented with colicky symptoms at 3 weeks of age, screaming and discomfort, and particularly in the evening. Bowel motions were normal. Growth was tracking beautifully along the growth centile, and the child was exclusively breastfed. At that stage, by 4 weeks, the first intervention from a health visitor was, why don't you use anti-colic drops? No significant improvement was seen, so by 5 weeks of age, the parental anxiety increases, a pattern that we see very frequently, and where we as healthcare professionals need to have a lot of empathy. So at that stage, maternal tiredness and lethargy has increased to such an extent that mom said, can't continue breastfeeding, I'm just exhausted. Then your second intervention occurred. That stage, a healthcare professional suggested a lactose-free formula. The parents then reported that between week 5 and week 7, there possibly was a improvement in symptoms, but then a relapse. And there were no other new symptoms. Child is still growing well, no eczema. The parents, as they do, went onto an online forum and read about the symptoms of cow's milk allergy, and by week 7 went to their general practitioner and asked for an amino acid formula and absolutely insisted on it. So the consequence then was the child disliked the formula, but the parents felt this was the right diagnosis, so actually were quite forceful in giving that formula, so the child started to develop a bottle aversion, so become quite an aversive feeder. And on asking the parents, were there any symptom improvements, they were like, we're not quite sure, we've not seen this magic moment. But they continue on the online forum, so the next demand on their primary care physician was another amino acid formula, because maybe it was the wrong formula that was prescribed. Again, the symptom improvements were very ambiguous, and the parents felt they should see full symptom resolution. So at that stage, a proton pump inhibitor was started, and they continued on an amino acid formula. This child was then referred onto a dietitian, but never saw a dietitian until 6 months. And at that stage only were they advised to reintroduce, with no deterioration in the symptoms at all. And only at that stage did they start working on the feeding aversion. And so you can see all these changes. If it was addressed earlier on, we would not have had a child that was a difficult feeder. We would not have had all these feed changes, and possibly one could have given the support for ongoing breastfeeding. On the other side, we also need to acknowledge the delay in diagnosis of cow's milk allergy. We still see that. So in 2010, health economic data showed from the UK that it took on average almost 2.5 months until the right treatment was started in children that had symptoms of a cow's milk allergy. And there were multiple visits to their general practitioner. Now, of course, that can change depending on your healthcare system. But we do have to acknowledge that there's an impact on the health of the child, from faltering growth to an increased risk of micronutrient deficiency, whether that is due to feeding difficulties or ongoing inflammation due to increased losses as a result of diarrhea and vomiting. But we also need to acknowledge the fact that the underdiagnosis can have an impact on the quality of life of the family. And there is an impact on the healthcare system as well, because the data from the UK showed, as I have shown with the child before, you have all of these changes in feeds and interventions, and they're going to see a healthcare professional, and that alone also has a negative fiscal burden on the healthcare system. So I wanted to show you also an example on the consequences of delaying diagnosis. And I think you can see from this graph, this is a growth chart from a child as well that I have seen, where you can see the story is all told within the graph of this child. I saw this child at 7 months of age, when this child was already diagnosed with a mixed IgE and a non-IgE mediated allergy. But this child has had eczema, and severe, poorly controlled eczema, since 20 days of age. Multiple treatments were started, no upper GI symptoms, so no reflux, but had raging diarrhea, so 6 to 7 watery stools and severe anal excoriation. And by the time that the allergist saw this child, the albumin was very low, and a food protein-induced enteropathy was diagnosed. Skin prick tests were performed. The child was negative on IgE. As already Yvan had shown, many children have raging symptoms but are negative on IgE. And you can see immediately that the faltering growth was corrected once the child was switched onto a cow's milk elimination diet. Again, you have the consequences on the other side. So the pendulum swings to both sides. You need to get the diagnosis right, avoiding underdiagnosis, but also overdiagnosis. And here we looked many years ago already at a cow's milk allergy pathways, in particular looking at what general practitioners know, because we wanted to understand what would be a pathway that they would be able to follow. And as you can see from this data, the vast majority were not aware of, for example, the milk allergy guidelines. Some were familiar with the NICE guidelines, which are the primary guidelines we use within the UK settings. And the feedback that we had was these guidelines were complex and were long and complicated. And I think part of this feedback also helped the birth of awareness tools. And here we already have a systematic review which really found only 2 awareness tools that were published. Many of you will say to me, no, Rosan, online we find many of them. The reality is, actually, whilst you might find questionnaires online, these questionnaires are not validated like a diagnostic tool or an awareness tool. And here, as Yvan has already highlighted, we are a big group of experts that have worked on a CoMiSS awareness tool that has already been existent for many years, and really is not a diagnostic tool, but there to raise awareness. There are more than 28 already original research papers, and by the time that most probably we have the end of the year, you'll have more papers, but it's a very robust tool. This tool, for those of you who've not seen it before, relies on a variety of symptoms, and there's different scoring, which we considered, we weighted this very carefully. One message, though, that comes very strongly across and that we reinforce is that if, for example, the child scores above 10, which increases your awareness and the likelihood of this being a cow's milk protein allergy, it does not exclude the fact that you still need to challenge the child after 2 to 4 weeks. And it also does not remove your clinical skills in terms of putting a picture together around the diagnosis and using the awareness tool just for raising the awareness. What we've also done as a separate group is we have provided, based on a Delphi consensus, guidance on how to use these questionnaires, and we've particularly identified that the tool, like CoMiSS, is one of the only ones available that has been validated, and that's really critical for us, is that any tool that is published like that has the right research. So if we come to the last conclusion of this presentation, I hope we both have shown you that cow's milk allergy remains a very complex diagnosis, in particular non-IgE-mediated allergies. And I hope I've demonstrated that there are underdiagnosis and overdiagnosis, and there are negative consequences to both of these. We have got tools, awareness tools, in particular CoMiSS awareness tools, which are really robust in raising your awareness, but that does not take your clinical judgment away, and also the fact that you need to challenge these children. And I'm going to end here and wanted to also highlight the fact that we have a further webinar on Thursday, the 12th of October, again by Professor Anja Novak and also Professor Yvan Vandenplas, talking about the CoMiSS score, in particular to raise awareness related to cow's milk allergy. Thank you very much.
Thank you, Rosan, for this beautiful presentation, giving us a lot of insights in the difficulties of diagnosing cow's milk allergy. We have now the opportunity for a question and answer session, and quite some members who participated to listen to you during this presentation had already some questions. And one of the ever returning questions, I would say, is diagnosis, overdiagnosis, underdiagnosis. One of the reasons which are brought up by one of the panel members is insurance covering cost of formula. Is that a cause of overdiagnosis? And I would like to add, what is the most harmful, overdiagnosis or underdiagnosis? What do you think?
First of all, thank you, Yvan, for leading this Q&A session. It's a complicated question. I'm going to break it up and start off with whether insurance companies agreeing to treat is at the cause. In my opinion, I think insurance companies are treating also reflux. So we could put that down for the overuse of PPIs. We could use it down for other medication. In my mind, the primary reason for overdiagnosis is that the knowledge and research, in particular related to non-IgE-mediated allergy, is not sufficient. It's really complex, and I hope I've demonstrated in my presentation that most of the symptoms overlap with symptoms that we see in other parts. And the second part, remind me what the second part of your question was.
What is most harmful? What is most dangerous? Overdiagnosis or underdiagnosis?
For me, I've seen both. And it's difficult to say that underdiagnosis is worse than overdiagnosis, because I've seen harmful effects on both. So my message would be that both have got significantly negative, harmful effects. But I think here the CoMiSS score can be really useful. As I said before, it's not a diagnostic tool, so it's awareness. It's an awareness tool. And I think by raising awareness, it helps with the underdiagnosis. But the step of challenging helps with the overdiagnosis. And I think that step is often skipped.
Thank you for your clear answer. But you brought up CoMiSS, which is mainly intended for non-IgE mediated allergy. What about the patch test? Is there an indication for the patch test?
So, Yvan, at the moment, I mean, we get the questions a lot, and I know a lot of clinicians use it, but the official statement still from IACI, Quad AI, is that patch test is not the most reliable test because sensitivity and specificity, depending on the type of patch test you use, is still not that of a reliability that you can say it is like a specific IgE or like a skin prick test that you have a high sensitivity and specificity for the patch test. So at the moment, no, it's not recommended as a standardized patch diagnostic test.
And is there a relation between dosage and symptoms, mainly in non-IgE mediated allergy?
That's a great question. So those curves that we see with food challenges where you start with your 4 to 5 challenge doses and you have a dose curve response, they don't yet exist with non-IgE mediated allergy. I think all of us have personal experience. Certainly for us within the UK who've worked on the IMAP guidelines, we recommend that for a week you have at least 210 milliliters on infant formula or equivalent amount of protein for a week to make sure that you have sufficient dose. I think we need still a lot of data. I'm sure you have seen in your personal practice also differences. We have shown with the milk ladder in our non-IgE in terms of different dosages that baked versus, cheeses can in different children have different responses. So the answer is yes, but I can't give you an exact milligram that you have an IgE-mediated allergy.
So it's probably also patient dependent.
100%. I think, and it's good that you highlighted FPIES versus a proctocolitis, totally different situation, 100%. Yeah. So thank you for bringing that up.
And is familial history, can that help us in diagnosing cow's milk allergy still today? What's the role of history?
So history, of course, is extremely important. And we know that a family history increases the risk, but we have plenty of families that have no family history, but they still have got cow's milk allergy. And in fact, now, so whilst in the IACI guidelines, when we're looking at who's high risk, IACI guidelines say that a first degree relative, that is a sibling or mother or father, increases the risk. But the Australian guidelines say that there's equal risk. So my message here is absolutely look at the family history, but that should not take away from the fact that you're still looking at that specific child, looking at eczema, looking at weight, looking at the feeding history and all of the symptoms. It's not one singular factor. It's actually a little puzzle that you put together and then challenge, challenge, challenge. That message cannot be more reinforced.
So how convince parents to accept that challenge test? Because parents often are very reluctant to it.
I think we all have our different techniques, and I think this is where the salesperson in us as healthcare professional comes in. So I prefer to pitch that sale at the time of diagnosis. So when we kind of go and say to them, we think your child may have, I already say to them, we're only prescribing X amount if it comes to a prescription or a maternal elimination diet, and you have to come and see me, we are going to challenge. So I actually do not let them go without that plan. And I would recommend that everybody has that discussion, not just when they bring them back, but actually from the start, because most parents are quite emotional when it comes to actually re-challenging and get quite upset by the re-challenge. But I think if we also tell them about overdiagnosis, and that has a negative consequence, you're keeping child on an elimination diet that doesn't need to be, also has a negative consequence. So I think often that sales pitch where we sell them the possibility of the diagnosis needs to be very open from the start. But it's a very difficult situation to have that discussion with the parents.
Okay, question for a dietitian. Should dietitians use CoMiSS in their nutritional assessments?
It's a great question. So my answer is, I'm talking from a UK perspective where dietitians are often first line, and my answer is absolutely yes. And the reason I say that, because in particular with non-IgE mediated allergy, we are often at the forefront of initiating the elimination diet and then referring to a gastroenterologist and allergist. So absolutely. But as a dietitian listening, do not initiate without thinking about the challenge.
Okay, we are almost running out of time, but I've got questions regarding treatment, role of soy and role of rice hydrolysate.
So you can jump in here, Yvan, because you were the primary author of ESPGHAN. So in terms of rice now, ESPGHAN guidelines, where in countries where it is available, suggested as a useful alternative in the elimination diet for cow's milk allergy, because rice does not contain any cow's milk. So, and there are more and more studies coming through around the safety and growth. I think the soya certainly, most of the guidelines recommend not to use until 6 months. And I think it's still a very controversial discussion. But it's becoming more and more that soy is being used. And I think in developing countries is a useful alternative if the cost of extensively hydrolyzed formulas and rice formulas and amino acid formulas are very expensive. Do you want to pitch in on that in terms of soy? Because I know you've done the ESPGHAN guidelines there.
Yeah, what we said about soy is that soy is a good second choice option after the extensive cow's milk based hydrolysate or rice hydrolysate, that if these are not available for whatever reason, soy is certainly an option. Last question, how do you challenge a child with a non-IgE allergy? Do you perform it at home? How do you supervise?
So current guidelines for FPIEs would be supervised challenge. For all of the others, we do not have the facilities to keep them in for 48 hours or 3 days to challenge them. So we do it at home, and every center needs to look at their services. So we do it at an initiating volume to make sure that they're okay. Most of the children have a skin prick test if they've got eczema also on board, just to make sure. And then I normally follow them up after 3 days, and again ask the parents up to 7 days. But you need to this is really important that you follow them up for enough days afterwards to really capture those reactions. And so I do say not only 3 days, it's important 3 days, but up to 7 days. And I make sure that they get at least 210 milliliters of infant formula or the equivalent in terms of yogurt if they're exclusively breastfed, or milk in foods or cereals, for example.
Okay, thank you very much. This brings us to the end of this webinar. Rosan, thank you very much for your very, very clear answers. So just to remind all of you, the next webinar is on October 12th, where you will learn a little bit more, I hope, about CoMiSS tool. Also, other messages, complete the feedback form posted in the chat. And of course, you all can download the CoMiSS and the user guide of the CoMiSS on the QR codes to be provided in the final slide that you see now appearing. And so thank you for your participation, and see all of you on October 12th. Thank you very much.
Thank you very much. Bye-bye.
Bye.